El doctor Nazha es gerente de práctica en el equipo de aprendizaje automático y de datos en el sector público de Amazon Web Services. Es un experto en el tratamiento de pacientes con leucemia, por lo que su investigación se centra en el uso de inteligencia artificial, aprendizaje automático y aprendizaje profundo para traducir datos genómicos y de atención médica complejos en herramientas clínicas útiles que pueden mejorar los resultados. Dr. Nazha, you can start whenever you wish. You are mute. Yes, we can hear you now. Great.
Great, thank you. Thank you very much, Maria, and thanks for the organizing committee for the opportunity to present today. It's such a great pleasure and honor to be with all of you today. So I'll talk about some of the state of the art of artificial intelligence in healthcare. In this talk, what we will cover, I'll start by covering the terminology. So what do we mean by AI, machine learning, and deep learning? Because just trying to set up the stage, because these terminologies typically mean different things to different people. And then we're going to discuss why medicine needs artificial intelligence. And I would argue that moving for the future of healthcare, we cannot move to that direction without AI. And then really spend the majority of the talk talking about the application of AI in healthcare and try to highlight some of the areas that we see significant activity and potential impact in healthcare. So what do we mean by artificial intelligence? So artificial intelligence is making machine think and do things like a human without explicitly programming the machine. So if a human can drive a car, can I make the machine drive the car without me telling each step for the machine? So that's kind of the big umbrella of artificial intelligence. Beneath that, there is machine learning. And machine learning is teaching algorithms with data. There are two types of machine learning. One is supervised learning. Supervised learning where we know the answer. So let's say I have a set of images of dog and cat, and I'm trying to run those through a machine learning algorithm. I will ask the algorithm to predict whether this is a dog or a cat, and then I'll hide the answer from the algorithm and then ask the algorithm to guess based on the pattern of the data. So that's supervised learning. Unsupervised learning is when we don't know the answer. So we ask the algorithm to find patterns in the data and then come up with the answer to us. An example of that in healthcare, if you're doing clustering, for example, for RNA-seq analysis, where we have a huge amount of data and are trying to group the patients in one or two clusters. Now, a subset of machine learning called deep learning, and this is an algorithm that's supposed to mimic the neurons in the human brain. So in our brain, you have the neurons, and those neurons are connected with each other. Those neurons fire up when we do things. If we try to mathematically model that, that becomes a deep neural network. But the easiest way to think about machine learning is that you have a set of input. This input can be a data, tabular data, an image, or a video. And you have a set of output, something you're trying to predict. So we have a classification problem. I'm trying to predict dog or a giraffe. That's a binary classification, dog, cat, giraffe, elephant. That's a multi-class problem. And then regression problem is a continuous number. So I'm trying to build a model to predict the house prices in Buenos Aires, for example. And then in between, you have an algorithm. If this is a machine learning algorithm, that becomes a machine learning model. If this is a deep learning algorithm, that becomes a deep learning model. Now, why medicine need AI? Now, we all realize that the amount of data that we are accumulating in healthcare is exponential. So if we look just on genomic data, it took us about 10 years and $100 million to sequence the first human genome. Today in the United States, we can sequence the entire human genome for less than $1,000, and probably in a few years we'll be able to do that in about $100. What that means that this type of data is exponentially growing. What that means that this type of data is doubling every 7 months. So if the trends continue, genomic data by 2025, it's just a few years from now, will surpass YouTube, Twitter, and Facebook data combined. Now, we're not talking about the electronic healthcare record data. We're not talking about the imaging data. That's just only the genomic data. So the question becomes, how do we store this data? I mean, if we think about whole genome sequencing, that's to store one is a 60 CDs. So let's say I have a 2 million whole genome sequencing. How do I store this data? How do I analyze this data? And this becomes really important conversations that we need to have in the future. And this is what medicine looked today. This is how I feel sometimes when I was rounding on leukemia patients in the hospital. But this is what medicine actually tomorrow and can be today. So if we imagine that the patients come to the hospital, we're collecting their clinical data and all their imaging and pathology data, we can now run multi-omic data, not just whole genome and whole exome, we're talking about RNA-seq, microbiome, and other type of transcriptomic data. If we put sensor data, so if we put a Fitbit or a Halo on their hand, we'll be able to measure their sleeping, their activity, their tone, their other sensors, maybe glucose monitoring, and then measure their also quality of life. And for the first time in human history, we'll be able to link sensor data to omic data, sensor data to clinical data. And the question becomes, if we blend all this type of data, can we build a model that can predict diseases before disease happen? Can we build a model to predict cancer before cancer happens? Can we predict outcome of cancer patients in better way? How they get a response to therapy and so forth. So I believe we live in the first time of human history to do biomedical research because of this amount of data. Now, obviously, the impact of machine learning has been growing on all industry, and the healthcare industry is a little bit behind. But what's really interesting, this is all industries, to say that a few years from now, the global spending on AI will potentially reach about $110 billion. So there's a lot of investment going in that space. But more importantly, about 75% of enterprise and organizations said they are moving from piloting to make AI operational in their hospital, and about 57% of them said AI will transform their business. Now, this is actually not in healthcare, it's still healthcare and behind, but we assume that in a few years, probably those numbers will translate into the healthcare system. So the application we see in AI in healthcare is really wide, and I'm trying to put some of the areas where we see activities but also potential impact. So we've seen a lot of activities happening in genomics, and I'll discuss that in more details in the next few slides. We've seen algorithms implemented or trying to be used to improve the diagnostic accuracy of our tools in healthcare. We've seen algorithm deploys in research and to enhance the collaboration in research. Precision medicine obviously is a big topic, and I think there's a huge opportunity for machine learning in a precision medicine, but also we see interest of the implementation of the technology for hospital operation. How do we manage bed batters? How do we predict patients' readmission, no-shows, and other? And I'll talk more about that. And obviously, how do we manage population? So as population health grow and the population grow, how do we manage them more effectively by decreasing the health care cost, which becomes really important. So when we talk about genomics and machine learning, there are different aspects that we've seen activity. That start at the beginning from data transfer and storage. So as we discussed, this is a huge amount of data. So how do we store those data? How do we analyze it? So cloud computing becomes an important part. Also, when you have a lot of data, what you would like to do is trying to automate tasks to analyze that data. So secondary analysis, if you upload the FASTQ, for example, files, can we automate the process to turn those into actual data? We'll also see significant activity of trying to integrate machine learning algorithm in the interpretation of the results. So when I get the result, how do I make sense of it? How do we build a model that makes sense of predicting outcomes? But also, how do we integrate this type of data, genomic data, with clinical data and imaging data? And there where we see a lot of applications of machine learning in that regard. An example, obviously, this is a new algorithm, came out of DeepMind, and that was very important because that algorithm was able to determine the 3D shape of protein structure from its sequence. Now, why this is important? Because determining that was very difficult in the past. And if we determine the protein correctly, the structure, then we'll be able to develop better drugs that can target those proteins that can, for example, lead to cancer or other chronic conditions. So that was a significant impact. Another study we have done before, prior to joining Amazon, is taking clinical data and genomic data and build what we call a personalized prediction model, meaning what we found that the survival for cancer patient, that what we predict using our staging tools, and when the actual survival is completely different. So using machine learning, we were able to build a model that can give you survival probability that is specific for a given patient. So what you see me doing on the screen, changing the clinical variables of the patient, changing the mutation, and you see the survival of that patient completely changed. The other opportunity, obviously big opportunity for AI and machine learning, is in imaging. And we discussed, at least in the United States, but I think that's globally, there's a huge shift between value-based care and just fee-for-service. So how do we take care of the general population with less money? But we also realized that we accumulated now digital data that could be pathology, any type of imaging in healthcare system. This is a huge amount of data. And also we have limited supply of radiologists. We have a huge shortage in the United States of radiologists. And the question is, can we supplement that shortage by using machine learning? Now, building an image, deep learning algorithm for image is really take time and effort, because number one, we want to make sure that we have the right images and those images are annotated correctly, which means that we need to have radiologists sometimes to review the images to make sure that they are reliable. So it becomes harder if I want to do a study of 100,000 images. Now, it's really hard to get radiologists to review all these images. And then we're going to train the model. But most importantly, how do we evaluate those models? What are the metrics that we're going to use as physicians and researchers to say the model makes sense? And what we've seen, and I'll touch more on that, is that some algorithms built in one healthcare system don't apply to other healthcare systems. So how do we assure that these algorithms are reproducible across the entire health systems, not just in the United States, but around the world? But if we think about computer vision and radiology, we have either classification, meaning the algorithm can say, you know what, there is a bleed in this CT scan, or segmentation, meaning the algorithm going to take a line and draw that line around the bleeding. And this type also require more involvement from the radiologist in the training part, because they have to label the data to the algorithm to say, look here. And then the third type, what we call it object detection. In other words, the algorithm will draw a box and say, there's a probability this is a bleeding. And now we're talking about integrated systems where we can integrate the three of them. So the algorithm could do classification and object detection. Now, if you think about the FDA cleared algorithms, we see probably now in the United States about 140 or more. I stopped counting. Now, this is FDA cleared, not FDA approved. Cleared meaning that we can use the algorithm in a hospital setting, but with the supervision of physician, not on its own. And we see application again of this. This is one example again. Can we use deep learning and those computer vision to try to say if a nodule on the CT scan, if it's a cancerous, or predict the risk of cancer of that CT scan? Another example, can we use those algorithms to, for example, take a CT scan of the chest and then turn the arteries of that CT scan into 3D models, which allow us to evaluate for stenosis on those scans. In other words, do we really need to do a cardiac cath to identify the stenosis as diagnostic tool, or can we use the CT scan with the AI algorithm to do that? Obviously, the application on imaging is not only radiology. So this is another example for taking the fundus of an eye and with the aid of the AI system trying to detect diabetic retinopathy. As you know, this is can be difficult, for example, for a general practitioner or a primary care physician to predict just looking at the eye. And if we try to scale this globally, there is a shortage of experienced ophthalmologists. So can we use the algorithm to kind of aid a general practitioner to identify diabetic retinopathy, because it has significant impact on patients' health? We also see impact on pathology. Again, this is imaging. It's part of the imaging. And about, I think, 2 months ago, there was the first FDA cleared algorithm to diagnose prostate cancer on pathology images. We also seen a lot of activities of other type of cancers, identifying normal cells on the pathology. So I think we will see more algorithm developed in pathology. Again, none of those imaging or pathology algorithms are FDA approved yet. So if we think about the application of AI, is really not just of imaging and genomics, but really, building models to improve patient engagements. How do we retain patients in the hospital? How do we follow patients after they leave the hospital, tracking patients? In the United States, we start talking about social determinant of health, health disparities, where some patients are not getting the same treatment like other patients. Another applications is the hospital operations. Can we manage hospitals and bed availability better by building models to predict, the surge of the patients that are going to come to the hospital? Building models now to predict readmission. If the patient has a high risk to come back to the hospital, can we prevent that? If we identify those patients with higher risk, can we build models to predict how long the patient is going to stay in the hospital? So we'll be able to manage beds better. So I think on hospital operation, we have many avenues that we've seen an interest and some implication of the AI system. Other examples of contact centers. Can we have chatbots and contact centers run by AI to answer simple questions from the patients and then direct the patients to the right representative? We've seen sometimes when we call the hospital that you get on hold for about a half an hour. Can we leverage the chatbot and the contact center from AI to try to improve that experience? And then obviously the devices, Alexa, can we put Alexa in the hospital where try to prevent patients from falling? Alexa at home, Alexa can remind patients taking their medications on time, can remind them with their doctor follow-ups, can provide some answers for them about their disease. So we've seen huge interest to the applications of these devices in healthcare systems. Obviously, there are still some challenges that we need to understand and recognize. One of those challenges when we talk about deep learning is that when we try to see where the algorithm is looking, explainability becomes a challenge in healthcare. In other words, we need to explain what the algorithm is doing for us to trust that algorithm. In this study, they built a model to predict pneumonia using an AI algorithm. But what the study showed, as you can see here, that the algorithm sometimes is not looking at the pneumonia to make the decision. Now, this can be scary and dangerous in healthcare. The other important part also, like, would patient accept the AI systems in the hospital? So this is a survey done for patients to ask them, if let's say an AI system read your CT scan, would you accept that? And what we found, there is a lot of concerns from patients about the safety. Like, if I have a cancer, do I trust the AI system to read it? Or I want the best radiologist in the world to read it, right? We've seen that patients are afraid that the algorithm discriminate of their choice of choosing the therapy. We've seen some concern about deploying those algorithms in the healthcare system can increase the cost, not decrease the cost, and everybody's talking about decreasing cost. And then also, do we identify biases? And this is extremely important. We have biases in the data, we have biases in the model, we have biases in the algorithms. And are these biases addressed? And does it really have an impact on the patient? So I think these are important questions that we need to ask ourselves before we start trusting and deploying those algorithms in the healthcare system. But nevertheless, I still think AI changed our life. We all use AI. You use Siri, you use your iPhone, use Uber and Lyft and all this stuff. AI will definitely advance cancer research, but not just cancer research and medicine in general. There's a significant opportunity for us. We still have some limitations of the technology. We just have to acknowledge them and then also work on improving them as we build these models. But finally, I think what's really important to recognize that the electric light did not come from the continuous improvement of candles. So if we really want to change healthcare, and build the future of healthcare, I think we have to completely change how we think about healthcare today. And we start embracing not just AI, but all digital technologies, start learning how to use this technology to impact our patient journey in the hospitals and their outcome. So with this, I would like to thank all of you for attending the meeting today. It was such a great pleasure and honor to be with all of you, and I'm happy to take any questions.
Dr. Nazha, thank you very much. Personally, I love the last quote here of changing the paradigms. We have some questions. To begin with, Juan Alvarez, he asked you, do you know any experience of the use of machine learning in critical care, taking into consideration the amount of biological science we have on critical care units?
Absolutely. So there are multiple efforts to build models to predict outcomes for critical care patients. So one of those is that we've seen some of those models deployed in the hospitals. Can we predict sepsis, at least in the United States? So can we predict sepsis early and then prevent, or hoping to prevent, patients from actually going into septic shock and die? We've seen also interest in building models to try to predict length of stay in the ICU, so we manage beds better, readmission to ICU. So when you discharge the patient from ICU to the floor, can we highlight the higher risk patients that they have a risk to go back to ICU, so we can allocate some resources to prevent them from coming back to ICU? We've seen some interest in trying to use computer vision, for example, to identify the tube placement on the chest X-ray, fluid management. How do we manage the fluids so where we're not over giving the patient fluids or under using fluids? So we've seen wide application and interest of the technology in critical care, and I think it will have a huge impact in that regard.
Great, thank you very much. I also was wondering if you have had the opportunity to validate all these algorithms with other centers, as you told us, something about domain shift and how these algorithms don't work well in other centers?
That's an excellent question. So one of the models that I showed you that we built prior for me joining Amazon when I was at the Cleveland Clinic, we took data from the Cleveland Clinic and then data from centers in Europe, and we externally validated the model in data from academic center in the United States. We also externally validated the model in data from a clinical trial, and also validated the model during the disease course and prior to sending the patients to transplant. So we did multiple validation and to assure that the model is reproducible, not in one setting, but in multiple clinical settings. And this is extremely, extremely important in healthcare. We've seen publications today of algorithms are built in one system and not validated in completely independent systems. We've seen algorithms that not validated when we try to implement them in the other healthcare system, say in Argentina, might not implement, giving the patient differences in the patient population. So we have to be careful about reproducibility of these algorithms prior to use them on patients in a clinical setting.
That's great. Thank you very much. And our last question would be, in your opinion, which are the biggest challenges and obstacles to solve or to overcome in order to achieve the adoption of these techniques all over the world?
Absolutely. So I think the biggest challenge in healthcare today, and if you wish, the delay in the adaptation of the technology is education. So we don't have the right talent. What I mean talent is in terms of data scientists to try to take full advantage of the data in the healthcare systems. Physicians and researchers, we as physicians are not trained on how to build machine learning models. This is a new technology for us, which means that, how do you judge the algorithm? Is this the right algorithm that used in this study? How do we judge the algorithm, output and when we implement it in the clinic? So I think education is the most important part, and we need to start integrating this education in our medical school, our training programs, where physicians grow with the technology and then they understand it. By understanding it, you understand the strength of the technology, but also you understand the weaknesses of it and how do you work with these algorithms? Because the way we view it is not really the technology going to replace physicians or researchers. I don't think that's what will happen, or at least what we've seen so far, or hopefully not in my career time. But we've seen that this is a relationship between the algorithm and the physician, meaning as a physician, I'll be a better physician when I use machine learning and I provide better care for my patient, when I know how to use those algorithms compared to physicians who don't know how to use the technology. So we need to get the workforce from the beginning to now to understand the technology and how do we work with it. Once we get to that point, then it becomes easier to say, you know what, this algorithm is good, this algorithm is bad, this methodology doesn't make any sense, and so forth.
Excellent. I agree with your answer. And I would like to thank you for your presentation and for sharing this space, your knowledge and experience with us. We'll give you the floor to our next speaker. And now I'll speak in English so as the audience to comprehend.